And it's really, as always, we always feel connected and as a good friends of Greek people, so it's always a pleasure to come here and see all the friends. And I have a small tribute at the end for that. So indeed, we're going to think about infliximab, this old age biologic that we still see on network meta-analysis to still be the most effective drug, even with the new ones coming around. But can we even push the clinical benefit upwards with a sub-Q? So these are the conflicts of interest. And indeed, the sub-Q formulations, the fact that we now have several drugs having both an IV and sub-Q formulations, specifically vedolizumab and infliximab, since about 2020, is interesting because these are opportunities for us to learn about the differences between sub-Q and IV in the same compound, which is something we don't get often in our biologics with our other biologics. So basically, the pharmacokinetics of IV versus sub-Q are pretty straightforward. When you give an IV in gray, you have a peak level which is very high. This is called the concentration max, Cmax. And you then get the trough level, the C minimum, the Cmin, which is way down below. Whereas when you give a sub-Q formulation, and this is true for every monoclonal antibody that is given in a sub-Q formulation, you get this slowly undulating line, which is much less pronounced in terms of this peak and trough levels. But the area under the curve for the design of the sub-Q infliximab was designed so that the area under the curve for the IV will actually be similar to the area under the curve, the drug exposure, as we call it. So how much our body is exposed to the drug is expressed by area under the curve, and by regulatory requirement, this has to be the same. So it will, whatever I'm going to show you, it actually teaches us something about the importance of the Cmax, the trough levels falling down, because the area under the curve is similar, which is something I think we need to remember because we will see the pharmacokinetics. But one immediate inference, which may be actually beneficial in the sense of sub-Q infliximab and some of the other sub-Q formulation, similar to adalimumab, for instance, is the fact that since these concentrations are quite stable from injection to the trough, which is not really trough, you can measure the drug levels at any time point through the 14-day cycle. And this was recently shown very nicely by Xavier Roblat, showing this in a 2-cycle of subcutaneous infliximab, where you get the same levels whenever you measure, whether it's on day 4 to 6 after the injection, up to day 14 or later or earlier on in the cycle. But if we look a little bit, and I think some of you or all of you have seen this slide, this is a slide that depicts the main clinical trial that was done, the phase 2 clinical trial that was done to establish that indeed the subcutaneous formulation is equivalent or similar to the IV one. And very quickly, all patients received an intravenous infusion at week 0 and 2, and at week 6 were randomized to either continue IV formulation as we are accustomed to every 8 weeks, week 6 and then every 8 weeks, or receive the sub-Q formulation every 2 weeks thereafter, with the primary outcome being pharmacokinetics at week 22. So not many people are aware of that, but again, by regulatory requirement, the primary outcome was week 22 pharmacokinetic equivalent, because the compound itself is exactly the same. So looking at the results from this, you can see, and now you will see that up until week 30, as you can see there, or week 22, you can see that what happens at week 6 is that indeed there is a depart of the two lines, the green line depicting the sub-Q versus a black line depicting the IV, when trough levels are measured. So the trough levels, as we are all familiar with intravenous formulation, go down below the 5 microgram per ml. If you look at the median of a population, this is a very often situation. And we usually think about 5 or 3 microgram or 5 or 6 microgram per ml, usually for our infliximab-treated patient, as one of the desires or one of the goals that we look for as a therapeutic target level in terms of PK. So you see that throughout up until week 30, they look quite similar. They look quite similar to what we know, whereas the green line depicting the sub-Q has trough concentrations which are stable and much higher in the range of 15 to 20. what happens after week 30? This time in the trial, those patients who were already the primary endpoint was ended, was analyzed, but then those patients on the IV arm were switched to a sub-Q as well. So the two arms there are then getting the sub-Q formulation up until week 54, and you see in the black line what happens to the concentration in those who were by week 30 receiving IV and then switching to a sub-Q formulation. So this seems to be quite established in the clinical trial scenario, but it's always important for us clinicians to look what happens in the real-world scenario. And there are several studies such that has been published recently from the UK cohort on the left, with quite substantial number of patients that were switched. Not all of them, actually most of them were not switched by week 6, so were switched whenever they were down the road during treatment, and this we will talk about in a moment further. So those patients who were switched, you see the concentration. Actually, they started with a median that was quite high. You see the concentration of nearly 10. But even with that quite high baseline concentration with escalated doses, etc., you see there was a bump in the median concentration thereafter to about 15. And similar results from the Spanish cohort with a lower baseline on IV maintenance. You see the baseline of 6 and going up to 18 and 19 thereafter. In a French large cohort recently published by Anthony Boisseau, what you see here is again a large group of patients, and he analyzed it further to look at what kind of dosing were patients before and what did it have to relate to the pharmacokinetics thereafter. So you see on the left-hand side patients who were on our standard maintenance of 5 mg per kg every 8 weeks. This indeed, once you change to a sub-Q formulation of 120 milligram every 2 weeks, this caused a significant rise in the blood concentration of the drug thereafter. And similar phenomena was shown also for patients taking double dose of 10 mg per kg or even 10 mg per kg every 6 weeks, still having a significant increase in their blood levels of the drug. But this was not the case when patients were taking quadruple dose. So patients who switched when they were taking 10 mg per kg every 4 weeks, actually the levels remained the same. So in essence, I think this is a very important figure for us to realize that when you switch to a sub-Q, you're pretty much perhaps escalating the effective dosage in terms of trough levels, not AUC trough levels. You're escalating the patient to perhaps a more efficacious trough level, as you would do with a quadruple dose. Now, what about efficacy? So these are the pharmacokinetics, but does it translate to any differences in efficacy? And this is where the picture becomes more complex. So if we look first, and again, I will have this inset that you see on the top to show you where are we on the clinical trial phases, because it's a little bit complex, so just to keep us focused on which stage are we talking about. So if we talk first on the first phase after the induction and then switching or not to sub-Q. So here you have the results up until week 30 of this phase, and you see that overall there was the combined clinical response for UC and CD and clinical remission were comparable between the two groups. If you look at biomarkers on the right-hand side, so not so much difference in terms of biomarker calprotectin, despite the higher concentration. If you look on CRP, in contrast on the left-hand side, you see there is a signal for a higher CRP, meaning higher ongoing inflammation, with the black line of patients continuing IV, as opposed to those in the green light that switch to sub-Q. Now, what happens later when those black line patients on IV finish the clinical trial but then were switched to the open label sub-Q, you see the CRP begins to go down and decline and meets the sub-Q arm, suggesting perhaps that in terms of control of inflammation and not the clinical response and remission that I showed you before, there might be a signal for better efficacy for the sub-Q formulation. Now, we all like for mucosal healing because we think that is probably one of the targets that we should aim to, certainly with high-risk patients. So what about mucosal healing? And you see that again in the short-term early phase of the study up until week 22, perhaps too short. So there was no difference, no statistically significant difference between the two arms. But what happens when these patients then switch to the other? You see that marked in the circle to the last stage of the study. So if you look at it, then the patients who were receiving the IV until week 30 and then switching, there seems to be a trend or a signal which is not statistically significant. This is a caveat, but if you look at the slope of the catching up of the mucosal healing, seems to be a little bit steeper, perhaps again hinting that with larger number of patients, this could even reach statistical significance, possibly. If we look at it from calprotectin, so this change indeed translates into a statistically significant difference within this post-hoc analysis that we published recently in this clinical trial. So on the left-hand side, you see what happens to those two groups at the stage of the study, at the late stage from week 30 to week 54. So patient in the orange are the patients on the left-hand side. You see the concentrations of the drug remaining stable, but the patient who switched at week 30, so this is like during maintenance therapy, you switch a patient, you see their median drug levels going up from 2.34 to 20, and this translates, and you can see that on the right-hand side graph, to a reduction, which is statistically significant, reduction in the calprotectin level for this blue group, which is those that were switched, late switcher to sub-Q, as opposed to patients who continued their sub-Q formulation and had a similar calprotectin from week 30 to week 54. Now, does this also translate to real-world evidence? And I think it's always important to look at the real world, with all due respect for the clinical trials. And again, coming from the Phil Smith at the UK cohort, a sizable cohort, looking at the calprotectin trend after switching. So you see the baseline, and again, baseline is anywhere along the maintenance when they switched patient to sub-Q, and you see there was a trend, also a same signal coming with a reduction in calprotectin, perhaps a better control of inflammation down the road after the switch. And this was also replicated with a statistical significant decline shown in the Spanish cohort, quite similar results for the calprotectin. Here, even the clinical response seems to be better. It's not clear in the paper whether they switched only patient in remission or not, so I cannot vouch on that specifically, but at least the biomarker signal I think is quite convincing. And coming to Anthony Boisson paper about the clinical efficacy in French real-world experience, so they looked at it in a different way, looking at the rate of relapse. And it's important to realize that when you talk about rate of relapse, it's important for us as clinicians because we are always afraid of these relapses, but this is a non-controlled intervention. So they switched everyone to sub-Q, and then they see what happens. You don't have not even an historic cohort to see what happens if you follow such patients. What is the rate of relapse in our everyday practice, for instance, in such a cohort? So this is a grain of salt to be taken when we consider it, but you see that patients who were switched on a 5 mg per kg every 8 weeks had within half a year, 6 months, the visit 3, had about 10% of relapse rate. This was clinical relapse. If they were on a 10 mg, if they were on 10 mg, so double dose, they had a similar relapse rate, so not much different. But if they were on the escalated doses, especially those patients who were already receiving 10 mg per kg every 4 weeks, had a higher relapse rate than before. Now, as I showed you before, when you switch to a sub-Q, you get a similar concentration as you get with a 10 mg per kg every 4 weeks. So this is a little bit bewildering, and I think this red bar, which is a little bit of consideration on the one hand, but for me, it tells me that perhaps if we would follow these patients who are already on quadruple dose, and we know those patients that we give quadruple dose, those are the patients that we had a lot of trouble down the road with clinical symptoms emerging, and we're chasing them with this increased doses over and over. I'm not sure what happens to them if you take this cohort, this specific cohort for 6 months and follow them, what would be the rate of relapse in them, and possibly this could explain part of it, but this remains to be seen. The conclusion that Anthony Boisson and his colleagues drew from this is that patients that you switch on the higher level, or if they come and you want to switch them when they have a 10 mg per kg every 4 weeks, then you better switch them perhaps to the 240 milligrams per every other week of formulation of this sub-Q infliximab rather than the standard sub-Q 120. And I realize that 240 is available in Greece as well. But I think what we can learn most is actually what happens when you dose escalate, again, with the caveat that you don't have control. So the lack of control arm is I'm using it both for and against the formulation, and I think that we all should be if we try to maintain intellectual integrity. But in this instance, if you look at dose escalation, so what happens to patients who switched, no matter what earlier dosing they were on the IV, so they switched to sub-Q, then they relapsed. But then the French group looked at what happened when they dose escalated those from 120 to 240, and you see a remarkable recapture of responses. Virtually everyone except one patient recapturing the clinical remission, and 12 out of 15, which was 80% of patients, actually recaptured combined clinical biomarker remission, as shown here. So it's a small group, and again, taking it with a grain of salt for the size of the group and a non-controlled observation, but I think it does teach us that we still have some room to play with, even if a patient flares after the switch. Now, what about immunogenicity? So for this audience, I don't think we need to speak much about what is immunogenicity, but I think we all are aware that sub-Q formulation are considered basically to be more immunogenic than the IV ones, probably because of the exposure. I will talk a little bit more about that later this day, but probably because of the exposure of the drug to the immune system via the dendritic cells in secondary and tertiary lymph nodes. But anyway, what is actually happening when you switch patients from IV to sub-Q with infliximab? And again, we'll talk about it much more in depth later on this day in the presidential address. But if you look at the results, there was a similar number of antibodies between the two groups, those that were switched to sub-Q and the IV ones. But if you look more carefully at the neutralizing antibodies, and these are the darker inside bars within each bar, so you see that the gray darker bar was actually statistically significant. I'm missing here the stars, but was statistically significant higher for those who were maintained on the IV versus those in green that switched to sub-Q. So suggesting not even that it's comparable immunogenicity, but perhaps, and again with the caveat of a post-hoc analysis that we have to be careful about, but suggesting perhaps a signal for lower immunogenicity with the drug. Just to know that all these measurements were done with a drug-tolerant assay, so it's not a problem of having higher drug concentration, sort of blunting the ability of the assay to detect antibodies. No, this was done with a completely drug-tolerant assay. So this was replicated actually with a real-world evidence, both in the UK and in the French cohort. The elicitation of immunogenicity switching from IV to sub-Q was either 0 in France and 7% in the UK that was using a drug-tolerant assay and did find 7% of patients with emerging immunogenicity. Again, no control arm, so I don't know what would be the rate of emergence of such immunogenicity in this population if they just continued IV that we know elicit also. So what are the reasons for this seeming paradox for why would there be similar or perhaps even reduced immunogenicity with sub-Q infliximab? There are two main explanations used. One is what is called high zone tolerance. So you're probably aware of the fact that we can desensitize patients for any hypersensitivity antigen that they have, as we do with B, as we do with some drugs, by injecting repeated low dose, minute doses, and upscaling the dosing. And this is what is called low dose tolerance induction. But the opposite is also true, that we know when we flood the immune system with a very high dose of, inject a very high dose of antigen, this sometimes also sort of signals to our immune system to ignore this and generate tolerogenic T cells, etc. And this phenomena is called high zone tolerance. So one hypothesis is actually, and you see that in the small inset with a PK figure that I showed you to begin with, perhaps by avoiding those low trough levels and keeping high doses all the time, you are in this high zone tolerance of induction of tolerating T cells. The other thing that could play is the immune complex, and maybe it's actually the same mechanism, just in a more elaborate way. And this work actually comes from Yuda Chower's lab in Israel. What they've looked at is looking at how many immune complexes, and immune complexes we mean the TNF molecule that is bound by an anti-TNF, infliximab. So what happens to those when you change the ratios between the infliximab and the TNF target? And you see that in the gel on the left side. So when you have different ratios of TNF to infliximab, you either get or don't get the TNF infliximab large complexes on the top of the gel, and you don't get them when you have a very high rate of infliximab, a 1-to-1 rate of infliximab to TNF. You don't see them. You have much more free infliximab. So how does that potentially translate? You see that in the graphics, if you have a high TNF and low, if you have a high TNF burden and low anti-TNF, no immune complexes will form, as you see in the graphic. This patient probably will not have a response, but this is a patient that you measure 0 drug levels, no antibodies. What happens if you have low TNF and very high anti-TNF in comparison? These are the patients that we hope for. Usually they will have a response. They will not form immune complexes because they cannot bind too many TNF together because there is low TNF to the high anti-TNF ratio. So you have no immune complexes, you have good measurable drugs, and good response. But what happens if this ratio is within this magical worth ratio of having high TNF but also not high enough anti-TNF? And that's what can happen, forming these large immune complexes where the ratio between the target and the antibody is such that this can form through the two arms of the Fab fragment of the immunoglobulin. And in this case, you will have initially a response because all the TNF alpha is caught by the antibody, but the immune complexes will then form the antibodies. So in Yuda Chauer's work, they've looked at this even further, and what they've done is actually look at macrophages, dendritic monocyte from macrophagic lineage. And you see in the red, these are infliximab TNF complexes. When you give them to these monocytic elicited cells, they get engulfed and phagocytosed to later be presented. But when you give infliximab alone, this does not happen. So APC antigen-presenting cells cannot take in the infliximab alone. And in a mice model, this was shown to indeed happen in the fact that when you inject to the mice infliximab only, you don't see any antibodies. But if you inject the infliximab with a TNF bound to it, so you get the complexes, then you see the mice developing antibodies against infliximab. And this is indeed a phenomenon that is known and was hypothesized by several authors before. If you have MAB underexposure, you get this target receptor immune complexes. But if you have the MAB in excess with high concentration, you will not get that. So coming lastly to safety, and indeed in terms of safety, there was no treatment emergent adverse events from switching to sub-Q in the clinical trial, except of course for localized injection site, such as we know from any sub-Q formulation. But all reactions were actually mild, what is termed as grade 1 and 2 reactions. I think another important aspect of safety is whether or not we should use mono or combo therapy with our infliximab compounds. And we know the benefits of using combo, but we also know the downside. And an interesting, I think, post-hoc analysis that we just now published again this year was looking with a caveat of a post-hoc analysis, so we need to take that into consideration, but looking actually at the patient within the clinical trial that were treated with a combo or monotherapy switching to sub-Q. And you see that actually on the left-hand side the figure, there was no difference in the concentration, and this translated also to no difference in the clinical scores and the clinical situation of this patient thereafter. So suggesting perhaps that similar to what Colombel has shown with the post-hoc analysis of the SONIC, if you look at the groups of patients that have enough drug level, in those patients, if the drug concentration is high enough, maybe we don't need the immunomodulator to get the same efficacy, and this could be at play with what we saw just now in the clinical trial. And if this is true with further evidence down the road, perhaps we can avoid or be more restrictive on using combo therapy with sub-Q as opposed to our more liberal use of combo therapy, especially for the first 6 to 12 months in patients with IV. And patient acceptance, lastly, is, I think, super important and often neglected area. Again, Antony Boisseau has done fantastic works on patient aspects, I think, in many ways. And I really like this study that they have done in a huge French cohort of over 2,500 patients, ask about their preference. And what you see that patients who have been already exposed to biologics, and these are the patients that we're now talking about, exposed to infliximab, for instance, switching to sub-Q, or to vedolizumab, switch to sub-Q. So these patients, as you can see, statistically significant difference in favoring the sub-Q every 2 weeks over IV every 8 weeks, let alone what happens to a patient who needs to do an IV every 4 weeks or 6 weeks. So this would be even worse, as you can see it on the right-hand side. But even our standard treatment patients prefer to get a sub-Q every 2 weeks over 8 weeks. So of course it has some cultural aspect, and these are French patients, maybe not always exactly the same as Israelis or Greek or Americans, but I think we do need to acknowledge that when you measure it scientifically, patients do prefer the sub-Q over the IV. And this was also shown in the later work by the French group looking at the patient that actually switched, and you see the level of acceptability for the sub-Q. Another aspect which I think I will have to note, and you know, some of you may be aware of my interest in IBD Passport, a charity that we formed with Kay Graverson, an English nurse, an IBD nurse, and helps people who are traveling. And part of the IBD platform on the internet, which is free, is also talking about how do you travel with medication. So I just draw your attention that the sub-Q infliximab is by the manufacturer USP, can be stored in room temperature up to 28 days. So this is another important thing for our traveling patients, this flexibility of using a sub-Q formulation that you can take with you if you have a business trip or anything, and you're not restricted by this scheduled visit to an infusion center. So my take-home messages, ladies and gentlemen, is I think sub-Q switching may have some benefits in terms of perhaps monotherapy, the self-administration for patient, perhaps also for high disease activity and the TDM strategy that we talk. We know that not all Costas are similar, even though they are all my friends, and there are several other friends here, good friends. So it's not all about the name, and perhaps sub-Q infliximab having the same name, but may not be a biosimilar, but may be a biobetter. And thank you for your attention.